Hannah. Welcome everyone to this evening's webinar, which is on swellings around the hand and wrist by Mr. Zekry. The plan for this evening will be the lecture and then any invited questions. So if you can pop your questions in the chat, I'll try and keep an eye on them and I'll ask Medhat at the end of his lecture. When we've gone through the questions, depending on the time, we'll invite people to have some Viva practice. So probably 2 or 3 people, depending on how the time is. And we want to aim to finish around 8:30. The lecture and questions part of this will be recorded. So if you miss a part, don't worry about it. It'll be available on both the OR UK website and the Orthopaedic Academy website, probably in a few days for you to rewatch the lecture itself. When it comes to the Vivas, I know some of you are coming up to exams in April. The best practice is always to put yourself forward. It's the best way to get rid of those nerves before the exam. And we've been where you are. We know how difficult it is, but it is the best way to learn. You'll be sent some feedback questionnaires afterwards, and we do read those. So if you have any comments, please put them in the feedback, and we hope to improve in the future. So just a quick note about the intensive mock Viva courses that are coming up. So unfortunately, these are later on in the year for the next diet of exams, but they're available on the OR UK website, which is oruk.org, and the Orthopaedic Academy website, which is orthopaedicacademy.com, I think, .co.uk, sorry. Without any further ado, Mr. Zekry is a hand and wrist consultant in Homerton Hospital. He's been trained internationally, and I've worked with him a lot on some of these courses. He's very knowledgeable, and he has some very good questions for you, and I'm sure his lecture will be very useful. So I'll hand over to you, Mr. Zekry. Thank you very much.
Thank you very much, Nikki. Really appreciate your warm introduction. Just share screen. Okay. Good evening, everyone. If you see anything in the presentation, or you can't see the slides, or any problem, let me know, please. Okay. And also the sound should be clear. So forgive me if I'm a bit exhausted, long day, but I will be really happy to talk till the end in the same power. So I'm Medhat, one of the hand consultants. We'll start today talking about the swellings around the wrist and hand. The aim of this talk, just to make it useful for you in the practice, not only for the exam, because all of us, we see hand cases, and it is important really to be aware of handling this kind of common problems. So starting with the clinical evaluation of swelling, it's exactly like any other swelling in the body. We take history, examine, and further investigations. So with regard to the history taking, you must take a focused history, either in the clinic or in the exam. It is the same. I kept telling my colleagues preparing for exam, please consider the clinic is a test for you with every patient. Don't take a longer time. Don't just, and also you should be efficient. It doesn't mean that you see the patient without picking up everything. You have to be very meticulous, but efficient. So starting with the history, just take from the patient what is the main complaint, the presenting complaint, then analyze it. If it is either pain, stiffness, swelling, any neurologic symptoms, then if any trauma, the trauma has a lengthy details. I have a slide of the history of the trauma. If we have time, we can share it. But I don't like to give too much information, and then you'll be lost. But it's important if you are dealing with the trauma setting. Then sometimes in the clinic or in the exam, the patient might be misleading you. You tell, I have pain in my hand. Yes, in the hand, because of the anatomy of the hand is unique, you have to be very precise ask the patient, please, can you point with one finger where is the pain? Instead of saying in the hand, and in the hand we have so many parts, so many pathology expected, okay? Then any associated symptoms with the patient, especially if something like a neurologic problem, you should analyze all the neurology of the patient in terms of paresthesia, numbness, any other cold intolerance, something like that gives you clue about the condition you are dealing with. Again, mechanical symptoms, it is important to know if there's any catching, any clicking, is it painful clicking, is it not painful? So you have to analyze all these symptoms thoroughly. Important to decide what options of treatment. You have to know the activity of daily living and hobbies of the patient, because this is important to decide what options of treatment you will offer the patient. Okay? Not every patient will, each patient will have to receive the same treatment. You have to tailor the treatment according to the patient's activity, living, job, handedness. So you will gather all this information from the history, and then you will proceed to the examination. I'm sure the history can give you clue of most of the pathology you expect to see. I prepared this slide, is good to summarize for you everything you need to know about the history of, of the examination of the swelling. If you see, comment on 5S, site, size, shape, skin, scar. 3C's like color, contour, consistency. 3T's, tenderness, temperature, and transillumination. Imagine 11 item. You can talk in any even long case. You can talk or comment on 11 item. This will give you a lot of information to deliver to the examiner. Then if you notice something else, like any deformities, either in the nail and the finger, anything surrounding the swelling, okay? Relation of the swelling to the tendon, nerve, artery, bone, and skin are crucial, because we'll come to the next few slides. You will see that the origin of these swellings arise either from soft tissue, bone, cartilage, or any other structure. Again, as a swelling, is it whatsoever the swelling, what is the impact of this swelling on the surrounding structures like neurovascular structures? Because you will see patient coming with lower ulnar nerve symptoms, and you discover in the end that there's a ganglion, okay? And again, the canal pressing on the nerve and giving these symptoms. So you have to analyze all these items in the clinical examination. Once you've done the history and examination, of course, before we move to the investigations, all the hand pathology are disease specific. But in the beginning, you should bring the patient quickly to scan the hand and wrist, quick movement, check about any pathology you can pick it up. So if it is a swelling, just focus on this swelling. You shouldn't talk nonsense about unnecessarily information, because it's not like the other joints examination. For example, the knee joint, you have to give details about everything, collateral ligament, meniscus, cruciate ligaments. But in the hand, you cannot. It is unlimited. So you cannot comment on everything. So once you talk the history, examine the patient, and then request the investigations. Normally we request, I normally like the X-rays as a baseline. You will be surprised to know that how much pathology you will pick up by the initial X-ray when you see the patient. So don't ignore the X-rays. Don't have this type of thinking that the MRI scan is the best. MRI scan probably one of the least investigations I request in the clinic, by the way. For example, if you have a scaphoidal problem, it is CT scan is the best. If you have a ligament problem, probably the arthroscopy is the best. So don't be running after just MRI scan for everything. I'm still believing that X-rays are important if you know how to interpret it properly and correlate it with the clinical situation. So, for example, X-ray like any swelling or any pathology in the bone, lytic lesion like this one, you have to comment on number of the lesions. Is it multiple in one finger or in other fingers, in the other hand as well or not? Location exactly, is it metaphyseal, diaphyseal, or epiphyseal? A zone of transition is important. So as we know from the pathology of the tumors, you can easily say this is might be malignant or benign or mixed based on the X-ray only. Then ultrasound scan comes as a real-time examination of most of the moving structures like tendons, joints. So we use it a lot in the hand, especially with the swellings. Okay. When you see any swelling, you ask yourself these questions: what is this swelling? What should be? What is the extent of this swelling? What I'm going to do for this swelling? What is the impact of the swelling on the function of the hand? And if you don't know the answer, yeah, what is this one? Just go for diagnostic test. What is the extent? Examine the patient and request some imaging, and then you can do subsequently a staging of the swelling, if it is benign or malignant or normal swelling of the soft tissues. Then if you are in doubt about the decision, just go for MDT. All of us, we attend useful MDTs because we share the decision about difficult cases in our practice. And then in the end, impact on the hand function, you do hand assessment if the swelling is something affecting the hand dexterity. Okay, so any swelling in the hand and wrist will arise from one of these structures. Is it bony, cartilage swelling, soft tissue? Is it benign, malignant, or intermediate? Okay, so this are the origin of any tumor. So you have to think logically when you see a swelling. Is it from a skin? Is it from the neurovascular bundle? Is it from the tendons? Is it from the bone? Is it from the cartilage? And then ask yourself, is it benign, malignant, or non-specific, or neurologic swelling? Then you categorize it accordingly. So, namely, these are the tumors or swellings which you can encounter in the hand and wrist. In the blue column, it's benign cartilage and bone. You can see the whole list. I will not go through this one. You can easily remember most of them. Even in the long bones like humerus, you can find the same pathology. On the other hand, malignant bone and cartilage tumors, again. Among this list, I will just come and speak about the melanoma, by the way. I'm not going to talk about malignancy in the bones because this is beyond the scope of this lecture. Then from soft tissue, we expect benign swellings like ganglion, lipoma, inclusion dermoid cyst, tenosynovial giant cell tumor, glomus tumor, gout, synovial chondromatosis. And I believe these are the list which you can expect in your exam. If you are focusing on for the exam purpose, which you should these days, these are the commonest tumors you will get it. I had in my exam ganglion was, I think, from acromioclavicular joint, something like that. So be ready for swelling in your exam because we have plenty, and the patient can be examined if you are examining the patient face to face. Continuous soft tissue tumors could be vascular, could be neural elements. Okay, so these are the categories of the tumors or the swellings we are going to discuss tonight. In more details will be the ganglion cyst, mucoid cyst, giant cell tumor of tendon sheath, glomus tumor, neural tumors, vascular, bony tumors, and melanoma. So for sake of, it is just attention to everyone. I will start with melanoma, despite you will never see melanoma in the exam. But this is important really for every one of us must know or at least suspect this is a melanoma. Otherwise, the patient might have a catastrophic future. It is serious disease and easily missed because all of us, we deal with the trauma to the distal phalanx and you see subangular hematoma, but don't simply explain that this is subangular hematoma when you see a little black discoloration of the nail bed. It is important to pick up this swelling. I think this picture, if someone, old patient came to your clinic and say, I knocked my finger maybe 2-3 weeks ago and it's still getting black, I don't think you should think in melanoma in this one. Sorry, in hematoma in this one. You have to suspect melanoma. You have to escalate it to the specialist, as you can save this patient's life and upper limb by early detection. As from this slide here, the prognosis of the melanoma is depth related, and if you pick it up early, definitely this patient might get benefit from amputation or some sort of treatment. So Breslow classification, thickness less than 0.7 millimeter or less carries the excellent prognosis. That's what we would like to catch these tumors in this stage. Thicker than 4 millimeter, you can see the survival rate is the worst one you can imagine. There is another detailed classification, Clark's classification. It deals with the depth of the melanoma and the distant metastasis if it is metastasizing. And you can see that in the picture here, something a bit can be overlooked by anyone. So be careful, keep high degree of suspicion, please, when you see something like that. Sorry, I tried to give this slide. Maybe it is not important for exam, but important for in life. I will not go into details about the treatment of melanoma because it will not be, I think, maybe important for the MCQ. Start the common swellings. The ganglion is a common in practice, in exam, in daily life is important. A lot of patients coming referred by GP, referred by other colleagues because of ganglion cyst, because of recurrent ganglion cyst. They had surgery, they had aspiration, and you have to deal with this situation. So you should know everything about the ganglion. Is it with a ganglion? I start with again history because I know where exactly the dorsal ganglion coming from. I X-ray the patient, I test for the scaphoid ligament and all the rest intrinsic and extrinsic ligaments to make sure that I'm not missing the main pathology with this patient. Then it will be categorized either to be idiopathic or some or second to degenerative changes. The origin of the synovial of the ganglion is modified synovial or mesenchymal cells at the synovial capsular interface. The outer wall of the ganglion is composed of multiple layers of collagen. The inner wall of the ganglion has flattened fibroblast and mesenchymal cells, no synovial lining, so this is not a true cyst. And we know why it is on and off, why it is fluctuating in size, because it has one valve allowing the synovial fluid to go outside the joint, but not returning back to the joint. It has this contents, I think all this information useful for the section 1, if someone preparing for the section 1. The ganglion from the radiocarpal joint is different from the ganglion of the tendon sheath, because tendon sheath one will be tiny and smaller in size than the dorsal ST ganglion or volar ST ganglion. But sometimes it's more symptomatic, by the way, when you have a tiny ganglion, you know, it is like the ureteric stones. If you have a small ureteric stone, it's so painful not like the staghorn stone, which you can incidentally discover it in the kidney. Sometimes it is not symptomatic. So the same with the tendon sheath, ganglion, because it can cause a lot of mechanical problems. These are the theory behind it. Again, the origin of the dorsal wrist ganglion from the scaphoid ligament most of the time. Volar ganglion could be from many other sources, commonly STT joint. The volar ulnar sided ganglion usually arises from the distal radial ulnar joint close to the TFC and bisotriquetral joint. Volar ganglion recurrence is high always after excision. I normally take plain X-rays even if it is normal, at least not to miss anything possible with the carpal instability. Then ultrasound scan if the patient is willing for aspiration and non-operative treatment, or MRI scan. I do MRI scan when I am planning for surgery. You see in this example here on the left side here, the MRI scan showing, you see the stalk, a narrow stalk coming from the dorsum of the capsule here of the wrist. And if you follow it up from the serial cuts of the MRI scan, you will find it's coming from the scaphoid ligament. When it comes to management, don't rush and offer surgery, because you have to be safe to do the surgery. You have to make sure that the ganglion is not going to recur again. It's safer to start at least with simple measures like aspiration. Sometimes the ganglion disappears by itself in 50% of the population. Sometimes it goes by itself. I saw recently a couple of patients, because they have been waiting for the operation, and they booked an appointment in the clinic, and they told me the ganglion is gone. So we canceled the operation because it can disappear by itself. Nowadays, we do it arthroscopically, because the idea just to take the stalk of the ganglion with 1 centimeter of the capsule. So just 2 portals, and one from 1-2 portal and one from 3-4 or 6R. Then you address the dorsal capsule, take the stalk till you see the tendon of extensor carpi radialis, and that's it, finished. You will find the ganglion itself evacuated inside the joint, and it rarely it recurs again. If you are going to do excision, open excision, you should do transverse incision, please, not vertical. And you have to excise again 1 centimeter from the capsule. Don't close it. You have to take it out with a stalk. And here, this is a recurrence rate in the arthroscopic versus the open. It's so minimal in the arthroscopic excision. Mucus cyst is another version of the ganglion cyst, but it affects the interphalangeal joints, the distal interphalangeal joints. This is another version of the ganglion. And the intrinsic thing is that the mucus cyst usually appears in conjunction with early degenerative changes, but not with the advanced severe arthritic changes. I see a lot of patients coming candidate for fusion of the DIPJ with deformity, with no joints at all. They never get ganglion cyst, sorry, mucus cyst. But you can find it easily in younger patient with subtly changed arthritic changes. And clinically, it has been always misdiagnosed by the GPs or other colleagues. Sometimes they think this could be a malignancy, it could be something dermatology. Rarely someone think about the mucus cyst. As you see, the impact of the mass here, as it is pressing on the germinal matrix, it can lead to ridging of the nail. In the X-ray, you can see the osteophytes and the arthritic changes. Okay. Treatment. This one needs, again, non-operative treatment is not successful most of the time. However, surgical treatment is important due to infection. It's quietly common infected, quite common open sinus to the joint. So we don't like to have such serious complication. It is better to be excised easily under local anesthetic. These are the, when you see a mucoid cyst, the most important, how to design your incision. It's not only to make a longitudinal cut or H cut or Y cut, Y incision. It's so important because the skin is not mobile in this area. And if you make a mistake and you lead to deficiency of the soft tissue coverage, the joint will be exposed, and this will be a big problem for the patient. So you have to think, what is your plan, how to plan for the incision. This is the most important. Normally, whatsoever the incision you are familiar with, the idea, you have to take the stock again, similar to the main ganglion. It will be lying between the collateral ligament and the extensor tendon. So you shouldn't injure any of these two structures, but you should excise an ellipse of tissue of the capsule with the cyst between the ligament and collateral ligament and the terminal extensor tendon. Coming to one of the other swellings, this is one of the patients I excised. You can see how big is the swelling, and from the thumb. I asked him, why did you didn't come early? He said, because of COVID, and I couldn't really come during COVID. So it is growing to this massive size, a giant cell tumor, or nodular tenosynovitis. You should know the other names. It is arising from the tendon sheath. You should differentiate it from the giant cell tumor of the bone. This is completely different entity. It's second most common soft tissue tumor. You see it in the hand clinic after the ganglion, commonly near proximal and distal interphalangeal joint. Histiocyte-like cells and multinucleated giant cells. These are the components of the giant cell tumor. No association of trauma, fracture, or any other scenarios. A strong association between rheumatoid arthritis and giant cell tumor. Rarely, it is locally aggressive. Recurrence rate, again, is a bit high, 10 to 32%. The treatment will be marginal excision. With such huge swellings like that, it is not only to make a cut, you have to plan the cut, you have to excise also the redundant skin, because if you look in the finger here, if you take it, chill out the swelling, you will leave by a big redundant skin, which you should plan again how to excise the extra skin. The same with the thumb. It was important to plan, when I planned to excise this one, how to avoid the neurovascular bundle, how to avoid the area of sensation in the thumb, because thumb is important part of the hand. Next swelling will be the lipoma. It's quite common to see it in hand clinic. It is benign tumor of mature adipocytes. It can be subcutaneous, intramuscular, extramuscular, or intraosseous sometimes when you do MRI scan or CT. It is painless, mobile, and stable mass, as you see from this old lady picture. The diagnosis is made by MRI scan, with the MRI scan studies, just especially with this age group, or if you have any suspicion about rapid growth of the tumor or the swelling, you should be careful. It's quite rare to have aggressive lipoma in the hand, but we know the lipoma in the back is serious. But in the hand, most of them, they are causing only either cosmetic problem or pressure symptoms. Treatment, if if you see the patient needs surgery, you need intervention or excision, you can excise it, just marginal surgical resection if it is causing troubles. We do this kind of operations under local anesthesia, by the way, wide awake local anesthesia. So this is not a big, you don't need to anesthetize fully. And this for more details, if you would like to get more details about the histology and the types of lipoma, if you have any questions in the MCQ. Going to another kinds of tumor, be careful. When you do a common operation like carpal tunnel syndrome, when you do decompression for the carpal tunnel, if you see the nerve doesn't look as normal as you expect, please don't do anything to the nerve. Take some photos, send it to the local peripheral nerve injury unit and close the wound. Don't do anything else. They will investigate further. If you have any clinical suspicion of a report of MRI scan or ultrasound scan based on your assessment, trust your assessment and the patient's complaint more than anything else. Because I have seen a lot of reports contradicting each other. Someone says ganglion, other says schwannoma, and in the end of the day, if you open this one up and you find it nerve tumor, the patient and you will be in troubles. You have to be very careful before opening to take any swelling. Make sure that you are confident this is not a nerve injury. So for schwannoma and neurolymphoma, they are common, by the way, in the hand in our practice. They are benign, yes, benign tumors, but we cannot deal with it because they need a microscopic surgical microscopy, which is not available everywhere, and it's better to be handled by the peripheral nerve injury unit. Male to female, 1-to-1, solitary or multiple, and exactly it is mimicking a ganglion or lipoma. Most of same patient, you have ultrasound scan says this is ganglion, MRI scan says neuroma or schwannoma. At the end of the day, if you are in doubt, don't touch this kind of patients. And by the way, the most important, the symptoms and the examination of the patient, because it will be giving a neurologic type of pain, not routine dull pain of ganglion or lipoma. Schwannomatosis, which is similar to neurofibromatosis type 2. They are both characterized by growth of schwannomas, but in the former lesions are late onset and may cause severe pain. MRI scan, again, it is just up to 80% accuracy to differentiate between neurofibromatosis type 2 and schwannoma. Treatment options, again, we refer these patients to the specialist, but generally either to observe or inoculation of the tumor from within the nerve. After the neurologic swellings, we have vascular swelling. One of them is a hypothenar Hammer syndrome. You can see this is an angiogram showing aneurysm of the ulnar artery, and it can be mistaken again as swelling, and you open this swelling up and you'll be again in trouble. So will be given from the history. You'll find the manual worker with repetitive microtrauma at the level of Guyon's canal as it passes over the hamate bone, leading to the vessel irregularity, aneurysm formation, or thrombosis. Aneurysm can cause compression of the sensory nerve branch of ulnar nerve, intrinsic muscles, and numbness of the ring and small fingers. A tender mass in the hypothenar eminence, pain in the palm, numbness, plus minus ischemia of the 4th and 5th digits. It depends on where exactly the swelling in relation to the zone of the ulnar nerve in Guyon's canal. Is it zone 1, 2, or 3? Differential diagnosis of hypothalamic Hammer syndrome will be benign tumors in the hand, as we mentioned before, lipomas, schwannomas, vascular, any other swelling must be kept in mind as giving a similar picture exactly like this one. Again, this one should be dealt by vascular surgeon or plastic surgeon who is dealing with microvascular surgery. Berger's disease is one of the differential diagnoses, which can present as irregularity. It has a corkscrew appearance on the MRI scan arthrogram of the hand, and it can mimic this syndrome. However, involvement of the digital arteries in the former, while involvement around the wrist joint in the Hammer, hypothalamic Hammer syndrome, will differentiate between them. MRI scan and MRI scan arthrogram can conclusively diagnose the syndrome by depicting aneurysm formation and pathognomonic corkscrew appearance. Vascular tumor, this might be seen in pediatric settings as the child will be born with something like that. And the differentiation between hemangioma and vascular malformation is important because both of them have different pathology, different course of the diseases. Hemangioma are characterized by variable spontaneous involution over time. Maybe this in this picture of the child may be hemangioma or vascular malformation. Diagnosing the lesion based on the history and examination. Treatment of hemangioma versus malformation is very different. Hemangioma will increase in size in the first years of life, but will involute or shrink by age of 7. A vascular malformation is present at birth and grows proportionally with the child. Continued with a vascular malformation, it will be associated with, as I think we know in other sites of the body, the impact on the general circulation of the patient. Pulsatility may be observed with the bruit, and larger lesions may cause steel phenomena. I think this could be in bigger lesions, something like the shunt of the dialysis. These cases should be, I think, will be dealt by vascular. But it's important to know the list of your differential diagnosis. Commonly, we encounter the glomus tumor. Sometimes difficult to diagnose it. It's not easy, but from the history again, it can give you some clue about the condition. So vascular tumor of glomus bodies. It happens in subangular region in the fingers and the deep dermal area of the palm and wrist. Again, it is not only under the nail, it can be happening elsewhere in the hand and wrist. Glomus body is a perivascular temperature regulator, and it could be solitary or multiple. This is the age group in the third and fourth decade. Diagnosis: exactly disproportionate pain compared to the size of the small tumor. Even sometimes you don't see the tumor in the early stage, by the way, but the patient describes exactly tenderness, neurologic pain, and cold sensitivity. You will be lucky if you see a bluish nodule under the nail with, again, pressure symptoms on the nail leading to ridging of the nail. MRI scan is diagnostic. You will not find any abnormality with X-rays or ultrasound scan. The MRI scan is diagnostic for this condition. Low signal intensity on T1 weighted scans and high signal intensity of T2 weighted scans. Histologically, it's composed of glomus cells, vascular channels lined by endothelial cells, and smooth muscle cells. The trouble when you open to take this swelling out, it is not easy to pick it up. It's not easy to find it. Sometimes you open and you can't find what you are expecting from the MRI scan. So be careful. You might open and close without taking it out. Recurrence rate is high. Okay, differential diagnosis will be leiomyoma or hemangiomas. can also present with the pain. Moving to bony swellings, this always mistaken as a dislocated carpometacarpal joints. Most of the patients, they have pain. They can give history of fall on outstretched hand at some point, but it is if you know the anatomy, if you know the story, probably you will be easy to or confidently to confirm this is not a fracture, dislocation, or subluxation. It's metacarpal boss. So the os styloidoitum is an accessory carpal bone located between the trapezoid, capitate, and second and third metacarpal bases. In women, 2 times more frequently than in men. Just seen a lady day before yesterday. The third or fourth decades, exactly. This is typical, by the way. The same lady was the same age. I see it frequently in the clinic. The result of abutment between the capitate and the base of third metacarpal of the trapezoid and the base of the second metacarpal bone during the wrist extension, causing the pain. This is a nice paper, if you can quote it. It shows the map of accessory bones, because you should be confident as orthopedic surgeon to say this is not a fracture, either accessory styloid process, accessory trapezium. You can see here about 25 or more type of 19 type of accessory bones. It's important to know this map, at least to say this is not a fracture. Again, we'll not spend much time, but the most important here, a CT scan can differentiate, of course, between the acute or fracture or coronal fracture or metacarpal boss. The treatment, again, don't rush and offer treatment for these patients because you might lead to carpometacarpal instability. So you have to be careful. Exhaust all the non-operative treatment, splintage, steroid injection, and again, excision. Be careful because you might overexcise the joint, and this will lead to instability. Osteodysteoma. This is again, this is a picture from one of the centers. Reported 25 patients, and these are the location of the osteodysteoma. It will be very subtle in the X-rays, but again, the history is typical of like any osteodysteoma. 12 of all benign tumors. See how much is common. Children and young adults, less than 40. It is self-limited, but I saw most of the patients, they are really suffering severe pain. Most of them, they have been mistaken as fracture because there is a history of trauma, which is just draw the attention to the problem. It produces intense signs and symptoms because of the prostaglandin secretion by the tumor cells. And that's why when we give non-steroidal, it gives some relief. To be honest, in the cases I have seen and I treated, I give them the same, either aspirin or stronger non-steroidal. It didn't make any difference, probably because of the inflammation and the changes in the finger, as you see from this 19-year-old university student. It was severely inflamed, and it is symptomatic, and it caused really terrible pain for the patient. Normally, we advise excision. We cannot wait years for the self-limiting nature of this swelling. And as you see from the X-ray on the right-hand side, there's a little nidus. By the way, MRI scan is useless for the osteodysteoma. It is just the CT scan. And intraoperatively, sometimes it's difficult to find this tiny, as if it is about maybe less than 1 millimeter. Other hard tumor, it is enchondroma. We see it most of the time in fracture clinic after minor trauma, they present with some fractures. You take X-ray, you find lytic lesion like this one, benign hyaline cartilage tumor that are thought to be derived from adjacent growth plate. The physial or metaphysial, it is quite common in hands. 20 to 50 asymptomatic year-old asymptomatic lesion discovered incidentally on radiograph. And these are the description of the X-rays. Treatment, most of the time we observe if the position is acceptable, if the symptoms are less operative, if there's embedding fracture close to the base of the bone or intra-articular about to invade the joint, you should interfere before damaging the joint. Chondrosarcoma, this is an aggressive form of malignant form, and this one should be referred to local tumor unit, not to touch these patients, either biopsy or any treatment. This slide will give you quick differential diagnosis between 4 common tumors encountered in the wrist and hand. Giant cell tumor, enchondroma, you see the characteristics are different, osteogenic sarcoma, and aneurysmal bone cyst. I just kept it for memorization. Finally, there are 2 systemic multiple enchondromatosis, two serious diseases, and they are inherited diseases. The first one, Olier's disease, is important. I think this in multiple choice questions. Skeletal dysplasia type with failure of normal enchondral ossification, enchondromas throughout the metaphysis and diaphysis of long bones. Involved bones are dysplastic with shortening and bowing. Risk of malignancy transformation is less than 30% compared to Maffucci disease, which is nearly 100%. With Maffucci, you can see in the X-ray here, there's some calcification due to vascular involvement or calcific phlebites. Okay, I think I tried to be quick to cover most of the topic. And now, if you see something like that, you have to know how to diagnose it. And thank you very much. Happy to receive any questions.
Thanks a lot, Medhat. I found it really interesting. I was doing the overnight fracture clinic today, and I had a prisoner brought in with a carpal boss, and then his prison officer showed me his Dupuytren's contracture as well. So, you know, even though I don't work in a hand unit, some of these things are still quite relevant. I can only see one question who asked at the beginning, why do we do a transverse incision for ganglion excision?
Yeah, because it is with Langer's lines, so the scar formation will be less. And you don't need a longitudinal one because we reserve the longitudinal. Even I don't do longitudinal per se, I do like lazy S cosmetically to avoid the keloid and scar formation. So the healing will be much better with the transverse one. The same, by the way, when you do the Kervan tenus advice, the Kervan first dorsal wrist compartment, you see the hand surgeon incision different from the non-hand surgeon because we do transverse incision or a chevron incision rather than longitudinal incision.
Okay, great. Thank you.